Afternoon, everyone. Good morning, good evening, depending on where you're joining from. This is our new normal for now. It's great to see you all here. We have about a few seconds before the session officially kickstarts. I want to particularly welcome those who are very keen on health financing and universal health coverage joining in. I think this is going to be an exciting session. Great, we're on time now. Good morning, good afternoon, good evening, good day, wherever you're tuning in from. Welcome to this session on financing for universal health coverage, which is part of one of the SIGs, the special interest groups within IHEA. And today's session will focus on financial protection and universal health coverage within the context of epidemiological transition and demographic transitions as well. We have very interesting presentations lined up. We have 4 presenters here today in no particular order of importance. We have one Vivian Nyakangi, who works with the African Population and Health Research Center in Nairobi, Kenya. Vivian is a researcher within the Population Dynamics and Sexual Reproductive Health and Rights Unit, and she is very, very interested in implementation of research projects that touch on comprehensive sexuality, education, abortion, and adolescent sexual and reproductive health and rights. Again, we have Patrick Ozenu, who is with the World Bank. Patrick is a senior economist at the World Bank within the Health, Nutrition, and Population Global Practice. And his work is basically around health equity, health financing, with a very strong focus on sub-Saharan Africa. And we have, again, Sridevi Pali, who is from India. She is a consultant and a health economist at the ICMR National Institute of Nutrition, which falls within the Ministry of Health and Family Welfare. Her interests lie within health economic evaluation. She's in Hyderabad in India. And lastly, but not least, we have Brianna Ostensky, who currently is with the Swiss Tropical and Public Health Institute, and her research interests within health systems development within low and middle income countries and how to improve access to care. She draws on different fields, including epidemiology, mathematical modeling, implementation science, econometrics, and many other methods. Without further ado, I would want to welcome them in the order that I have just presented. I'll give the floor first to Vivian. Vivian, you have about 8 to 10 minutes to present. Let's try and keep to time so that we can give the floor to participants for comments and questions. I want this to be lively. So thank you. The floor is yours, Vivian.
Okay, thank you so much, John, and welcome all to my presentation titled The Effect of Chronic Diseases on Catastrophic Health Expenditure on Kenyan Households. So the background, financial risk protection is one of the key components of universal health coverage, and the main aim is really to enable individuals or households to access the much needed healthcare without facing financial hardship. However, in most low and middle income countries, the primary source of healthcare financing is actually out-of-pocket payments, and this exposes most households to financial hardship and the negative impacts of out-of-pocket payments, such as catastrophic health expenditure and impoverishment. In Kenya, the healthcare system is heavily dependent on out-of-pocket payments for healthcare. For instance, the 2017 national accounts, as per the 2017 national health accounts, 27.7% of total health expenditure was accounted from the out-of-pocket health payments. Additionally, only 19% of Kenyans are covered by any form of health insurance. And that means at least 4 to 5 Kenyans have to pay out of pocket when accessing healthcare. Overall, chronic diseases have been found to increase the likelihood of a household incurring catastrophic health expenditure of course, due to the long-term need for healthcare and consequently health expenditure. And these different types of chronic diseases have been found to have varying effects on the effect of to have varying effects on OPP expenditure, depending on their severity and associated treatment costs. So in our country, currently, we don't have any data to show what the effect of different chronic diseases is on catastrophic health expenditure. And that really formed at the heart of my research. So I had two main objectives in my study. The first one was to compare the incidence of catastrophic health expenditure of household with and without chronic diseases and across the different types of chronic diseases. And the second one was to determine the effects of different types of chronic diseases on catastrophic health expenditure. So I used the WHO methodology to estimate CHE, which is catastrophic health expenditure. So according to the WHO methodology, a household is deemed to have incurred catastrophic health expenditure if its out-of-pocket payments exceed 40% of its non-food expenditure. So non-food expenditure is used as a proxy of the household's capacity to pay. So the incidence of CHE, which is the also known as the head count, is the proportion of households that incur CHE in the population. To estimate the effect of each chronic disease on CHE, I used logistic regression. I conducted bivariate and multivariate analysis, controlling for social demographic and socioeconomic factors that have been found in other studies to have an effect on CHE, such as household characteristics such as the age, the gender, the education level, the employment status, and other household characteristics such as the household size, the residence, whether it's rural or urban, and other characteristics. So I used the Kenya Household Healthcare Expenditure and Utilization Survey of 2018. This is the latest survey of its kind. There have been waves since 2003, 2007, and 13, and this is the latest in the country. So the survey was a nationally representative survey with a total of 31,655 households surveyed and 141,132 individuals. Overall, 37.8% of households had at least one member with a chronic disease, and 13.8% of individuals reported to suffer at least from one of the chronic diseases that were asked in the survey. So the distribution of chronic diseases, the most prevalent chronic condition was hypertension at 3.2%, followed by other respiratory diseases, and then asthma, HIV and AIDS, diabetes, mental disorders, TB, other cardiac diseases, and cancer. And maybe to mention at this point that I took these diseases just as they were collected in the survey. So like you can see, you could wonder why there's asthma and there's other respiratory diseases. That's how they were just administered in the survey. So I just picked up the way they were administered in the survey. So the distribution of OPP, out-of-pocket expenditure. So I analyzed the median OPP across the different spending categories. That's in terms of outpatient expenditure and in terms of inpatient expenditure. So across the different spending categories, individuals who had a chronic disease incurred higher expenditure as compared to those without a chronic disease. And as you can see from the table, outpatient expenditure was much higher than inpatient expenditure for both individuals with and without chronic diseases, but much higher for individuals with chronic disease. They highlighted rows are for the highest expenses. So the individuals spend most on outpatient medications, dialysis, and surgical operations. So on the incidence of CHE, overall, in the population, that's on your far right, the 7.96% of households incurred CHE. Then when you disaggregate across household with and without chronic disease, those with chronic disease, the incidence was 10.1%, whereas those without chronic disease, the incidence was 5.9%. Then across the different chronic diseases, you can see that households with an individual who had cancer incurred the highest had the highest incidence of catastrophic health expenditure at 22.7%, followed by TB, diabetes, hypertension, cardiac diseases, mental disorders, asthma, other respiratory diseases, and HIV and AIDS. So on the effect of different chronic diseases on CHE, so the effect was significant for hypertension, diabetes, cancer, TB, and other cardiac diseases. And overall, having a member in a household with a chronic disease increased the likelihood of a household incurring CHE by 2.2%. Cancer increased by 7.6, I can't see the figure, 7 point something percent, diabetes 3.5, TB 3.4, hypertension 1.9, and other cardiac diseases by 0.9%. Limitations to my study. First of all, the chronic diseases were self-reported in the survey, and therefore there's a potential of them being underreported or misreported. And also there's a potential of recall bias, especially where respondents were required to recall their household expenditures for longer periods like 1 year or 1 month. And also I do know that the comparability of these findings may be limited by differences in methodologies of determining or estimating CHE. So I used the WHO methodology, which puts a cutoff at 40% of non-food expenditure, but there are others that use 10% of total expenditure. And also the thresholds vary for different studies. So from my study, some of my policy recommendations would be, first of all, selectively enhancing the NHIF cover. NHIF is our public insurance fund. It's called the National Hospital Insurance Fund for chronic illnesses to reduce out-of-pocket expenditure, especially for outpatient services, and also subsidizing treatment costs associated with chronic illnesses such as dialysis, chemotherapy, and surgery. Thank you.
Thank you very much for that very snappy presentation, Vivian. And it's very illuminating in the sense that we know, given evidence elsewhere, that chronic diseases account for significant burden of out-of-pocket payments and could impoverish or push households into incurring financial catastrophe. So good evidence coming there from Kenya. Next on the list is Patrick. So Patrick, the floor is yours. You have about 8 to 10 minutes. Thanks.
Thank you very much, John. Let me share the screen. Can you confirm if it's coming okay on your side, John?
It's clear, but if you can switch to slide mode,
of course.
Great.
Exactly.
Thanks.
Okay, thank you very much. So hello everybody, and thanks a lot again for connecting to the session today. I will briefly present now the results of a recent joint work with my colleagues Sven Nielsen and Mark Smits from the health unit at the World Bank. So this work is closely related to the ongoing effort to jointly monitor with the World Health Organization the universal health coverage target in the context of the Sustainable Development Goals, especially the sub-target 382 on financial protection. And this monitoring work heavily relies on collecting and standardizing as many household expenditure surveys across countries as we managed to get access to. And the idea of leveraging this large collection of surveys to analyze financial protection and aging patterns stemmed from discussion we had with Adam Wack's staff, who was really instrumental in pushing this work, this monitoring work forward. So conducting this analysis was yet another reason for us to remember Adam and to pay a tribute to his legacy. Another motivation for this work is the strong global trend towards aging societies due to reduced fertility and to improve survival. And the tendency is really strong in almost all regions, and only sub-Saharan Africa has so far withstood that trend due to slower decline in birth rates and also to the heavy toll of the HIV pandemics. So usually for health systems, an increasing population share of the elderly is often thought to threaten progress towards universal health coverage, as was discussed by Vivian in her earlier presentation about Kenya. And indeed, if health coverage is insufficient, the elderly are particularly exposed to catastrophic and impoverishing out-of-pocket payment because they often face a double burden of both decreasing earnings and increasing out-of-pocket payment due to higher and more complex healthcare needs. So in this work, in this paper, we focus on two main research questions. The first one is aging driving part of the variation that we see in financial protection across countries? And that's a level of analysis that's conducted between countries. And the second question we are asking is if there's a higher relative financial risk faced by the elderly compared to the younger population. And here we look more at within country differences in financial risk exposure. In terms of metrics for financial protection, we rely on two metrics that have been widely used in the literature and that are part of the SDG monitoring work on financial protection. So we focus on catastrophic payments. So that's the share of the household spending either more than 10% or more than 25% in out-of-pocket payment in proportion of their budget. So in proportion of income or consumption. And we also look at the medical impoverishment, looking at the share of households pushed below the international poverty line at different threshold again. So $190 per person per day, 3.20 or 5.50. Now, turning to the measurement of aging. So ideally here, we would like to analyze the effects of aging and financial protection using individual level data on total expenditure and out-of-pocket payment. The problem we are facing here is that typically household surveys collect expenditure data at the household level and not at the individual level. So our unit of analysis here is the household. So we need to derive a household level measure of aging. And to this end, we borrow a concept from demography, and we define old age dependency ratio as the number of households aged over 60 years old who are considered old age dependent, divided by the number of household members who are potentially active, so in the working age category, which we define here as being aged between 18 to 60 years old. So how do we operationalize this measure now? So based on this old age dependency ratio, we consider three categories of households. The first categories are the household with zero old age dependency. So these are households for which there's no members that are 60 or above in age. Then we have a category of households which we define as facing a low dependency ratio. So this is when the OADR is less than 1/2, which means that these are households for which there's at least 2 potentially active members per old age dependent. And then when this ratio goes above 1/2, we consider that as being a high dependency households because we have less than 2 members, 2 potentially active members per dependent, per old age dependent. So we turn now to the first question. So we ask whether the share of the elderly explain variation in financial protection across countries. So that's the between country level analysis. So in that analysis, we use both the measures of financial protection and old age dependency as just defined. And we conduct here a fixed effect panel data regression using country year observations. The financial protection and the age dependency data come from the same household surveys, and they are aggregated at the country level. And in terms of covariates, we use the global health expenditure data and the World Development Indicator database. So the main result we see here, consistently with other findings in the literature, is the absence of a clear positive association between aging and financial protection at the aggregate country level. But this angle of analysis between countries does not, however, inform us on the potential gaps that may exist between the elderly and the younger population within countries. And that's the second question which we now turn to. So for this second question, we are pulling all available micro data sets together. So there are over 500, which cover 133 countries, which together represent about 90% of the world population. So that gives us a very large data set of about 9 million households with household level observations. We define the financial protection and the old age dependency metric consistently with what we did in the previous section. And we run OLS regression, so pooled OLS regression with country level fixed effect and controlling also for year specific effect. And in addition, what we can also do with this micro data is to look at the equity gradients in the aging effect for financial protection using consumption expenditure quintiles for our measure of socioeconomic status. Before turning to the regression results, I'll spend a bit of time on the descriptive analysis. So we saw conceptually before that the low age dependency ratio marked households for which we have more than 2 potentially active members per all dependent, and the high category, high dependency, marks household for which we have less than 2 potentially active members. So in practice, what we see is that our measure of age dependency is close to 0.3 in the low category, which means that in the low category, we have more than 3 potentially active members per all dependent. And it's close to 0.9 on average for the high dependency category, which means that there's only close to 1 potentially active members per dependent. We see also that these dependency ratios varies across world regions and also across income groups, with an increasing dependency associated with the increasing income groups. Overall, we have an important share of households who have old age dependent members, so over 30% if you combine the low and the high categories. But most of them, 22% here, are categorized in the high old age dependency ratio. Down here. And so here again, the proportion of household in the high dependency category also increases with the income group. So going from 15% for low income countries to 27% for high income countries. Finally, on the descriptive statistics, if we look at the proportion of households spending more than 10% of the budget, we also see that this is steeply associated with the age dependency ratios. So with only about 6.3% on average of households with no dependents spending more than 10% of their budget on out-of-pocket payment, but that share almost double, I mean, more than doubles for the high dependency household. And here again, what we see is an increasing trend of the difference between the elderly exposure and the non-dependent household exposure to catastrophic payments. It increases with the level of aggregate income from low to upper middle income countries, but then it kind of stabilizes and reduces slightly when we move from upper middle to high income categories. But these are marking basically for upper middle income country that household in the high dependency category are 3 times as exposed than the household in the no dependency category in terms of financial risk exposure at 10% of their budget. Oops. Sorry. Turning now to the regression results. We are plotting here the coefficient estimates for the effect of old age dependency, the predictive margin, on the share of households spending over 10% of their budget. And this is broken down a different bracket of the consumption expenditure distribution. So what we see
you have 2 minutes.
Okay, I'm about to close. What we see is that the old age dependency household are always facing a higher exposure to catastrophic payments than the younger household. And that gap is actually much wider for the poorer segment of the population compared to the richest. It narrows down mostly because the elderly are able to reduce a bit their exposure only when they are getting to the fourth or fifth quintile of the socioeconomic distribution. The others, the household with a medium dependency ratio or low dependency ratio, have a relatively stable pattern in terms of exposition across socioeconomic status. So now to conclude, again, I wanted to point out to the fact that aging ideally should be done with individual level data, but financial protection indicators typically rely on household level data. So we try to accommodate this by constructing a household level measure of aging. The measure of financial protection we have is also not perfect because in this analysis, we're only looking at those who are spending on out-of-pocket payments. So we're not looking at foregone care, and that would be an interesting extension for this work. So finally, we saw that aging as a driver of differences in financial protection across countries only appears to play a small role when we look at the between country analysis. But the picture really changes when we look at within country analysis and when you try to focus on the extent to which elderly households are facing a different risk compared to the younger household. And we found that the risk is twice as likely for the elderly compared to the young, and 50% more likely also to be impoverished by out-of-pocket payment. The age gradient is stronger in upper and middle-income countries in terms of financial protection exposure. And equity-wise, we also see that the strongest age gradient is in the poorest quintile. So coverage extension should really focus on targeting the elderly, particularly the poorest, in terms of expanding the universal health coverage financing policies. I'll stop here. Over to you, John.
Thank you so much, Patrick, for the presentation. I think this is a very important piece of work, especially given that societies are aging. It's known now that the current population in terms of those aged at least 65 years globally has increased beyond the population age at least at most 5 years, the under 5 population. So populations over 65 years exceed under 5 population currently. So this is something that is very important, especially as countries experience aging. So without further ado, I would want to quickly call on the next presenter, who is Sridevi. Sridevi, the floor is yours.
Yes. Good day, everyone. Hope you're able to see my screen.
Yes.
Yes. Yeah. My paper is mainly on the non-communicable diseases. It is a trends analysis between 2000-2016, and I came across the data this non-communicable diseases and felt that I should write a paper relating to that because of the huge number of deaths attributed to non-communicable diseases among all the world globally. So my co-authors are Naveen Kumar and Kader Babu, and this is on among the BRICS nations: Brazil, Russia, India, China, and South Africa. And globally, we can see that a majority of deaths are due to non-communicable diseases, like almost 71% of all of this are due to this, and majority of them are in the, and nearly 1/3 of them are in the productive age group of 30 to 69 years. And they basically are more disproportionately affect the people in the lower income and lower middle income countries. And as per the WHO 2021, and non-communicable diseases, as you all know, they are majorly cardiovascular diseases, then cancer, then diabetes, and COPD, that is the respiratory diseases. These are the major diseases which come under the non-communicable diseases as per WHO. Now, this paper is on BRICS nations. So an overview of the the economic and demographic view of these countries gives us a picture of all these BRICS nations, where the population is also population, the GDP, life expectancy is higher in China compared to other countries, and gross national income per capita is higher in Russia, and population growth and poverty head count ratio is higher in South Africa compared to other BRICS nations. Coming to the main objective of this study is to assess the trends among the BRICS nations, trends in non-communicable diseases during the period 2000-2016, and to investigate the impact of health financing on the NCD mortality rate and observe the trend, the factors influencing the NCD, deaths due to NCDs across these countries. And this also, another objective is also we also try to investigate the increase in non-communicable, what are the factors, the risk factors also we try to assess, and we came across the trends in consumption of fruits and vegetables and its influence on NCD mortality rate. So, and this is the second data based analysis with data from the Global Health Observatory of WHO. And growth rates were estimated to assess the trends, then association between NCD deaths and period of study. Period of study was done through linear regression analysis, and regression analysis was also done between the current health expenditure and NCD mortality rate among these nations, and the relationship between vegetable consumption and age-standard NCD mortality rate was also modeled through correlation. Now, the trends in NCD deaths among BRICS nations, it shows us that in 2016 alone, the number of deaths in all the BRICS nations together account for 18 million deaths, with highest number of deaths in China, around 9.2 million deaths in China alone in 2016 itself, and around 6 million deaths, 5.9 million deaths in India, and 1.6 million deaths in Russia, and so on. Now, the regression estimates between the NCD number of deaths attributed to NCDs and the time periods reveals that among all the countries like Brazil, China, India, and South Africa, the number of deaths due to NCDs is the highest among all the CVDs is the highest among all the NCDs, and except in Russia, where the number of deaths due to CVDs is declining, while on all other countries, the deaths due to CVDs has been increasing steadily. And of course, there is a marginal increase or decrease in COPD or diabetes. Now, the trends in current health expenditure among the BRICS nations reveals that this is also a regression analysis between the CHA, current health expenditure, and the time period. And current health expenditure per capita has increased over the time, and the highest increase is visible in the blue line is Brazil, and the lowest is in China with around just in India. In the blue line, that is in Brazil, it is around $49 per annum. The increase in CHE is $49 per annum, while in India it is the lowest, that is around $3 per annum. Coming to the current, an association between the current health expenditure per capita and NCD mortality rate also has been modeled through regression analysis, and we found that the regression estimates between the current health expenditure and NCD mortality rate, for every $1 increase in current health expenditure per capita, the NCD mortality rate declines by 0.14 in Brazil, 0.42 in China, and 2.35, the highest decline would be in India, and 0.42 in Russia, and 0.23 in South Africa. So we can see that this is the major, if with increase in current health expenditure per capita, there might be decline in NCD mortality rate. And to further assess the, and we have also viewed that, estimated the metabolic risk factors and biological risk factors. Of course, the slides are not here because for lack of time, I think it will not be sufficient time. So we have assessed the metabolic risk factors among the BRICS nations, and it is found that among all the countries, China has the lowest metabolic risk factors like overweight, obesity, or increased hypertension and all. Compared to all other BRICS nations, the lowest levels are found in China. So to investigate further into the reasons for the lowest levels in China, we further investigated into diet. So we have found that the vegetable consumption per capita is the highest in China compared to all other countries, where it is around 337 kilograms per annum per head in China, while in all other countries it is less than 120 kilograms per annum. And similarly for fruits also, the Brazil has the highest consumption up to 2010, while it has equated to almost to China from 2011 onwards, fruits consumption. And to further assess the association between vegetable consumption and age standardized NCT mortality rate, we have done the correlation, and it is found that the association between vegetable consumption and age standardized NCT mortality rate is found to be statistically significant, and with the negative correlation with all, while for all other countries it is negative correlation, but it is statistically significant for China. And this reveals that high vegetable consumption might reduce the NCT mortality rate to a considerable extent. Of course, we do not have the limitation of this study is that we do not have the individual level data. It is aggregates among all the countries. And the major conclusion is that healthy diet, regular physical activity, avoiding harm from tobacco and alcohol use can not only help individuals to lower the blood pressure and all, but reduce the risk for several NCDs. And more important should be, and given on the current health expenditure per capita increases, study reveals that current health expenditure per capita increases, NCD mortality rate would certainly decline, highlighting the need for investment in per capita expenditure for better health outcomes. And we underscore this study further underscores an increase in consumption of fruits and vegetables will lead to a decline in NCD mortality rate. And as per WHO, the 400 grams of fruits and vegetables per day per head, excluding the starchy vegetables, would certainly reduce the risk factors for NCDs. And preference to unsaturated fats over saturated and trans fats would be recommended as per the WHO, and less than 5 grams of intake of salt intake is also recommended. So if we take all these diet restrictions and improve the physical activity, then certainly the number of non-communicable diseases can be reduced to a considerable extent. Yeah, thank you.
Thank you very much, Sridevu. This is a very important presentation. Though it uses correlation methods, it's able to demonstrate the powerful message. One of them being the last one, although not totally significant, that vegetable consumption is very important, vital for reducing NCD incidence. And though the research didn't look at different pathways, which may be more complex than it seemed to have shown.
Yes.
It might be, for example, a way to start to begin to now look at the different more complex pathways. I want to pause quickly to highlight a few things. The evaluation is ongoing, so please, you can go to the website. I put the link in the chat box. Select that and just briefly evaluate this. IHEA is keen to improve its offering going forward, and evaluation results are very useful in making changes, good changes. And the second one is, feel free to post questions in the chat box as we go. As I've seen that there are no many questions in the chat box. And that's why I'm keeping everyone going to the next presentation. If there were to be a lot of questions, I would have paused a bit to allow for the presenters to present, to answer the questions. So feel free to drop questions in the chat box as we move along. We have the last presentation left, after which perhaps towards the end, I will introduce myself because I knew people asked, I didn't really introduce myself. I was so keen to introduce the presenters, but I'll talk about that towards the end if time permits. So without again further ado, I would want to invite the last presenter, but not least, Brianna. You have about 8 minutes. Thanks.
Excellent. Thanks so much. Alrighty. And you're able to see the screen there?
Correct. All correct.
All right, so today I'm going to be talking about health financing under demographic and epidemiologic transitions and really modeling the growing cost of claims for the Tanzanian National Health Insurance Fund. Let me go on to the next. So access to quality health care without risk of financial hardship is at the center of the global push for universal health coverage. And the Tanzanian health sector strategic plan includes effort to move towards UHC through plans to scale up coverage for existing health insurance schemes and to also move towards a single national health insurer. And health financing strategies for both this coverage scale up and for development of single payer require an accurate evaluation of the current healthcare use and reasonable projections of changing healthcare needs into the future, which is why we also projected it out with our modeling. And this is especially crucial in the era of the demographic and epidemiologic transitions, as everyone else has been talking about so far, as the healthcare needs of this growing and aging population are really changing. And this includes an increase in chronic care as the prevalence of non-communicable diseases rise. And so that really changes the needs of the system. And this is important in Tanzania, where only 32% of the population has any health insurance, and it's very fragmented between both formal and informal sectors. So the Community Health Fund, or CHF, or also now it's the Improved Community Health Fund, so ICHF, is designed for the informal sectors, and it's completely voluntary, you can pay in. And the National Health Insurance Fund, the NHIF, is what we're going to be focusing on today. And that comes more in the formal sector. So the NHIF is the most comprehensive health insurance program in Tanzania and covers approximately 9% of the population. It was originally established in 2001 as the compulsory health insurance for civil service and has since expanded to voluntary enrollment options for public employees and retirees, students, private individuals, and employees of private companies, associations, and NGOs, if those companies, associations, and NGOs have opted into having that be part of the provision. Within this formal sector, the premium cost comes from 6% of monthly salary for the principal member divided between the principal member and the company that's paying for it. And beneficiaries at standard include the principal contributor and spouse and up to 4 dependents. Now, the 4 dependents don't have to be children. They can be your parents or your in-laws. And so there is some, that's important to keep in mind moving forward, because there is a little bit of adverse selection that happens because of that, because it makes more sense to insure your older family members who are going to possibly need more care, especially because in Tanzania, the access to and cost for care for under 5s is really covered by the health system. The benefits from the NHIF include inpatient and outpatient care services, physiotherapy, rehabilitation care, optical services, dental and oral services. It's really comprehensive. Beneficiaries can receive care from both public and private facilities within the network of over 7,000 accredited NHIF facilities, which is about 79% of all health facilities, public and private, in Tanzania. So the methods that we use, the data source we're pulling from is the NHIF records from 2016. The beneficiary records include age, sex, membership type, and membership ID, of course. And then we were able to link that with claims data through the identifiable membership information, which comes with information on type of service, so consultation, medications, date and location of service, and also service information. And that includes things like what medications were dispensed, what consumables, and other kind of more finer grain information there. So we used that information on the service type to create these attributable condition categories in order to be able to have a better idea of kind of the broad trends and broad breakdowns of healthcare use in this NHIF program. So the condition categories are more cardiometabolic and respiratory NCDs. This includes things like diabetes, hypertension, COPD. And then cancer, all cancer treatments that were clearly identifiable, mental health and neurological disorders, which include treatments for epilepsy, Parkinson's, depression, anxiety, and then communicable disease, which grouped all viral, fungal, bacterial, and parasitic infections. Then we had some dental care, maternal care, and childbirth. While most of that is actually covered by another mechanism within Tanzania, there are still certain components such as cesarean sections and fertility treatments that are included in this data. And then injury and surgery, broken bones, surgery without clear attributable co-treatments, and then other that just we weren't able to readily attribute to any of these clear categories. We then broke down the claims into 5-year age groups separated by male and females, and calculated the pre-enrollee cost of claims from each treatment episode by the registered beneficiaries within each group. And we also looked at the number of claims within each group. But today, since we're having such a condensed talk, I'm only going to present the cost. And then the predicted impact of the changing demographic factors from 2020 to 2050 under 3 different coverage scenarios, accounting for changing demographic projections. We drew from the population predictions from the UN World Population Prospects and used a conservative estimate that age-specific burden of NCDs won't be changing. So most of that drive will actually be purely from the demographic transition. The 3 coverage scenarios we had is the status quo, so at about 9 to 10% of the current population covered. It's not perfectly representative of the underlying population because, as I said, it tends to be an older population than the underlying population. And the next scenario is if the coverage reached the goal proposed by some of the health strategic plan projections where they discussed aiming for 50% coverage by 2025. And then the next is a 10% annual growth in coverage, which has actually been what has been happening for the past several years. So kind of if we were to take that actual annual growth coverage that's been happening and scale that up into 2050. So quickly looking at the beneficiaries in the sample that we had, there were almost 3 million enrolled beneficiaries with a mean age of 30, standard deviation of 20. And so that's what I meant when I said that it is actually a much older sample than the underlying population. 53% are women. 51% of the enrollees and beneficiaries actually have 0 claims. And the number of episodes where we kind of grouped, if you had medication and a consultation, and we put those into episodes, the number of those is, the average is 2.2, but if it's greater than 1, the average number of people who had at least 1 had 4.4 episodes within the year 2016. So this graph is that breakdown of the NHIF claim cost per person by the broad treatment category. And we're looking at the cost per enrolled beneficiaries in 5-year age groups broken by gender. And as you can see, we have it broken down by all of these major treatment categories that I discussed before. And over time, as the population ages, you see a dramatic increase in cost with age. And this is driven by substantial increases in NCD costs, so both the cardiometabolic and respiratory NCDs and cancer. And while women of reproductive age actually have a higher number of communicable diseases and higher cost of claims for communicable diseases, that decreases over time. And as males get older, the cost jumps up, and actually the cost per beneficiary for males ends up being much higher than for females by over the age of 60.
You have 1 more minute.
Okay, all right. So then this is the projected from 2020 to 2050. The baseline is 124 million for the total cost of the NHIF claims. And under scenario A with the status quo, while it looks like a small increase here in comparison to the others, it's more than double to 363 million. Whereas scenario B with coverage up to 50% by 2025, so that's why it has that big jump there for 2025. The cost is 2.2 billion US dollars, and for scenario 3 with the annual growth of over 10, like just over 10%, the total cost is 2.8 billion. So it's a substantially higher number of treatment episodes and costs for older adults, and the volume is really driven by that increasing proportion of claims for NCDs. The growing age and aging population will really likely drive increase in use and claims costs, and NHIF policy will require accounting for projected changes from each of these. So the strengths of this is it's a comprehensive record of claims showing actual consumption across the NHIF program, and insurance claims provide this really rich data. However, there are several limitations. There's no diagnosis in claims, so the classification is inexact. We were able to draw from the records and medicines, but there is inherently limitations to that. And the population sample is not representative of the total Tanzanian population. There's limited information about the beneficiaries to actually identify differences between the sample and total population, so we can't really collide those very well. And then it is a conservative estimate because we say there's no change in age-related prevalence of NCDs. And let me just briefly conclude, and then I'll wrap up. So this used available administrative data, which is really important to model the economic value of the NHIF service claims. And the predicted claims value is that the NHIF is going to be facing huge financial challenges in the coming decades. However, despite this growth, we project also that the increasing NHIF coverage would probably result in high cost of claims, but is actually closer to the goal of UHC for less than 1% of the projected GDP. So we think that's a fairly good one. All right, and stop share there.
Thank you very much, Brianna, for that presentation, taking us into Tanzania, and also for us to see, well, like any other important factor, the importance of insurance is also is key. I know there's a couple of questions. We have about less than 10 minutes or thereabout for questions. There are questions in the chat box. Some of them require a very simple answer. So I would ask you to maybe engage with the chat box as well to answer a few questions. Like one, to should they be asking whether you use per capita or not, should be easily answered without opening the floor. But I will read out a couple of questions, and maybe you will address them one by one if I call upon you. But before we go further, I would want to say that there's detailed presentation somewhere online that you can go back to and listen to, either watch or read the slides. So feel free to go back and engage with more detailed presentation posted online. Now there is a question here from Marina. Marina is asking this to Brianna. Do you know if 0 claims per year for 51% of the population is normal, or would people have paid for small claims themselves and not filed a claim?
That is a great question, and we did find that really interesting too, because it's actually very high to have that percent be having 0 claims. As best as we can understand, because we're still trying to investigate that issue because it seems quite big, is that it might be that not that it would be paid for small claims themselves, but like I said, children under 5 and also most maternal care is actually covered through a different mechanism, so there wouldn't be any claims for it. So I think that's probably what's driving a lot of that 51%.
Great. Then there's another question here from Zunda. And Zunda is asking this to Vivian. Great presentation with some insightful results there. In terms of policy recommendations, he is wondering if it wouldn't make more sense for the government to focus even more on preventive measures on the 4 known modifiable risk factors for chronic diseases, for example, alcohol, sugar-sweetened beverages, tobacco, and physical activity. So Vivian?
Yeah, absolutely true, Zunda. It would be good to focus on preventive measures, but we do know that chronic diseases are quite burdensome to the economy. So preventing them is one way, but also trying to cushion these people who already have them to, not to incur catastrophic health expenditures is also good for those who already have them. But I do agree that also recommending preventive measures is a good thing.
Great. There is also another question for you, Vivian. Sorry if I missed it, coming in from Ian. Did the data allow you to look at comorbidity? I imagine it didn't, but it may be interesting to see the impact of comorbidity on catastrophic health expenditure and out-of-pocket payments.
Actually, it was possible to look at comorbidity from the data, because in the survey, respondents were asked for each of the chronic diseases to say yes or no, so you could be able to get comorbidity. But in my analysis, I didn't get to that extent. But it will be interesting to do that to see the impact of comorbidity on CHA and OPP.
Great. There's also a quick one we have from Brendan, and Brendan is asking this to Patrick. He asks that the association of old age with more out-of-pocket payment is more likely linked to the extent of NCDs among the age group. Is it possible to adjust the dependency measure developed to extract the effect of the chronic conditions that is reported in the survey? This question is because the policy choice could be age, population group, target versus benefit package. Considerations to cover the specific conditions driving out-of-pocket payments. I'm not sure whether you understand that. But...
Thanks, John, and thanks, Brendan. Yes, no, I think I get the question, and the short answer is no, because you would need disease-specific expenditure data. So doing that with as many household surveys as we looked at is really difficult because of the heterogeneity in household survey design, basically. But it's not impossible that in specific cases you have a survey instrument that allows you to look at these issues. And if that's the case, then if you have disease-specific expenditure data, and even better if you have these at the individual level, then yes, I think that's the way to go. Now, stepping back a bit, so I think that the hypothesis that NCD is driving a lot of these results is a very solid one. I just wanted to caveat this by the fact that when we are looking at old age dependency ratio and financial protection measures, we're not only looking at the numerator of the financial protection measures, but also at the denominator, in the sense that in a household, if you have one old age dependent, the situation in terms of dependency is different if there's one potentially active members or more than one that can actually provide some kind of risk insurance or some kind of risk pooling mechanism. So we consider the household here as a risk pooling unit, which can cover the expenses of the elderly and can thus prevent this elderly population to face financial risk due to medical expenditure. So there's the two aspects. There's the numerator, like expenditures are expected to increase with age, but there's also the denominator, so total consumption or total income, which is likely to be more stable and more solid in the case where you have less dependent per potentially active household members.
Great, thank you. And we've run out of time. I'm going to do the last round in a couple of seconds. I just want you to tell the audience what you want them to go home with. Just in just a very short sentence. I want you to go home with this. Yeah, let me start with Brianna.
All right. I think if you're, in order to achieve the UHC goals, accounting for the rising prevalence of NCDs is going to be crucial to doing appropriate financial health financing planning for honestly most countries in sub-Saharan Africa, definitely, and especially Tanzania.
Great. And you, Sridevi? You're muted.
To reduce the incidence or prevalence of NCDs, more awareness should be on diet, especially, and increasing the physical activity. So that is very important to reduce the risk factors for NCDs.
Perfect.
So the this awareness should start from the schools itself, so that from childhood itself, the children will be more aware, though they are aware of, but more stress need to be given. And also the public spaces need to be provided by the governments to, so that people will be doing the physical activity to reduce overweight, obesity, which is also increasing across the countries.
Great, thank you. And Patrick?
So yeah, to push UHC and to focus on equity, really focus on the poor and focus on the poorest of the poor, because it matters, especially after the crisis we've been through. Correct.
And lastly, Vivian?
Yeah, chronic diseases are not homogeneous in terms of their the extent of catastrophic expenditure, and therefore to push the country to achieve UHC, they must be able to consider the differences within the different chronic diseases in terms of the extent of out-of-pocket payments for healthcare.
Thank you very much. With that, I really want to thank all of you for your excellent presentations, and also the panel, the people who joined in, and the support team we had from IHEA. This has been really wonderful, and I hope you learned a lot. Sorry we couldn't take all the questions for time, but feel free to engage with each presenter. Their details can be found online. Chat with them, take them to rooms where if you want to chat with them, you could go further and build the networks. Thank you so much for stopping by. I wish you a good day further. Bye-bye.